talking about obesity, has new therapy changed our thinking in practice? So here are my disclosures. So to cut to the chase, the answer is not yet. So the new therapies that are on the horizon have not yet changed our thinking in practice. But I tell you what has changed it. So COVID and Boris. So the fact that Boris was admitted to intensive care with COVID, he had this kind of realization that maybe his own adiposity had something to do with it. And it soon became clear that actually people living with obesity were at risk of severe COVID-19. And this has changed NHS England, number 10, and the Departments of Health view of obesity in ways that I didn't think were possible in such a short period of time. So there's been a lot more new funding. So 100 million was first announced. In the comprehensive spending review, there's a lot of money that is a multi-year settlement coming to the establishment of specialist weight management clinics. And there's also going to be a national obesity audit that's going to go from cradle to grave, replacing the Red Book, mandatory entry of data to do with weight and comorbidities. This is going to be launched the 1st of April. I'm part of the panel that's doing that. But this is going to allow us for the first time to get real data of what's happening at the sort of real life coalface to see what interventions do and what we can do going forward. So over the last 25, 30 years of me seeing people with severe obesity, we've been kind of a bit stuck. We've had lifestyle or bariatric surgery. And the mantra from the public and also professionals was, well, obesity is personal responsibility. Simple. Eat less, move more. But alongside that, the scientific understanding of body weight regulation and the genetic architecture of obesity has markedly advanced. And there's been this disconnect between the, well, it's just simple, eat less, move more, versus the science, which was saying things that were very different. And now finally, many professional organizations and countries recognize that obesity is a chronic, progressive condition or a disease. And back in January 2019, the Royal College of Physicians called upon the government to recognize obesity as a disease, stating that it was a complex, multifactorial condition with genetics, health inequalities, etc., all playing into obesity. And unless we actually recognize it as a disease, then it's never going to have the money, the attention for prevention and treatment that it deserves. So why? Why should obesity be recognized as a disease? Isn't it just a risk factor? Well, obesity impacts upon every single organ system in the body. And in particular, it's the metabolic effects of obesity that we've been hearing about this morning. So type 2 diabetes, cardiovascular disease, certain cancers, impacts upon the joints, impacts upon obstructive sleep apnea. And then there's the psychological impacts of obesity with increased depression and anxiety. And as I've mentioned already, people living with obesity are at increased risk of COVID-19. Now, the reasons underlying that are complex, but probably reflect the underlying systemic inflammation that people with obesity have. And if we look at a person with a BMI of 40, they only have a 50% chance of reaching the age of 70. So obesity impacts upon life expectancy. It also impacts upon quality of life. But the good news is that weight loss leads to improved health. So we can do something about this. But the amount of weight loss required to impact upon the different complications of obesity varies. So if you think the Tier 2 digital weight program that the NHS has rolled out, on average, causes 3 kilograms weight loss. So if I have a patient who weighs 100 kilograms, losing 3 kilograms is not really going to help them. If you have a BMI of 25, 26, 27, then losing that amount of weight will make a difference. But if we want to really impact on NASH, obstructive sleep apnea, cardiovascular mortality, and engender type 2 diabetes remission, then we need 15% weight loss, which is really hard to achieve just through a lifestyle intervention. Having said that, this slide, if I can move on to it, there we go, shows you weight loss on the y-axis from 14 different lifestyle interventions. So ranging from 4.5 kilograms down to 30 kilograms. So showing that weight loss is achievable. And we know this from the direct study. But the problem is, if you follow up these participants for 4 to 7 years, then the vast majority regain all of the weight that they've lost. And we know that. We've seen The Biggest Loser and the follow-up from Kevin Hall's work, that people who lose weight tend to put it all back on. And I watch the space for what's going to happen to the NHS soup and shake intervention. So why is that? Why do people lose weight and put it back on? Because there's nothing worse from the patient's perspective. You've lost 5 or 6 stones in body weight. And then everybody's congratulating you, you buy a new wardrobe, you buy new clothes, but you put the weight back on. Can you imagine how disheartening that is? So we understand why. So when in evolution would you stop eating? We wouldn't, would we? Why would you suddenly cut your calorie intake down to 600 calories a day? You'd do it if we were in a famine. So famines, to us as a species, represent a threat to existence. So we've developed powerful biological responses to stop us from dying during a famine. So as soon as a person goes on a diet, then there's an increase in that appetite-stimulating hormone ghrelin. There's also a reduction in the satiety hormones that tell your brain that you've eaten. There's a decrease in energy expenditure, and when we use functional brain imaging, the brain responds completely differently to food cues. So it lights up like a Christmas tree as soon as you put a high-energy food cue in the environment. And it's these compensatory changes to a starvation that drive the weight regain. Now, some people can manage this for 1 or 2 years, but after a while, the biology really kicks in, and then they tend to regain the weight. So what does clinical management of people with overweight and obesity look like? So this is the current stepwise approach. So all of us should be having a healthy diet and doing physical activity. Then for people with a BMI 25 or more, then we add in behavioural modification across the piece. For people with a BMI of 27 or more with an obesity-related complication, then we can consider pharmacotherapy. And for people with a BMI of 35 or more with a complication or a BMI of 40 or more, then we can consider bariatric surgery. So this is the current kind of NICE-based guidance that we have. Now, the problem is the pharmacotherapy bit has been a treatment gap. And to be honest, at the moment, all we have is orlistat and liraglutide for a select few. So there's been a gap in our treatment options. So when I've been seeing people with severe obesity, my options have been diet that they've already done to death or bariatric surgery with not a lot in the middle. And if we look at the sort of the history of obesity pharmacotherapy, it's not been great. It's been marred by safety issues. Fen-phen, sibutramine, more recently leucovorin. So it's had 2 problems, poor efficacy and poor safety. So that's where we've been. But finally, the science that has occurred over the last 25 to 30 years is finally coming through. So this is just a few selections of advances in this area. And one of the critical findings is that we now realise that the gut plays a critical role in regulating energy and glucose homeostasis. Now, this makes sense because it's the first point of contact of nutrients with the body. So the gut releases a myriad of hormones, which then act upon the brain and the pancreas to regulate body weight and also glucose. And then on top of that, we have the enteric nervous system, the microbiome, and also bile acids. And acting together, they are key to regulating body weight. More importantly, in our current environment, where we eat not because of hunger, because of the rewarding aspects of food, these gut hormones not only act on the homeostatic parts of the brain, like the hypothalamus and brainstem, they modulate the reward regions of the brain. So this slide on the left-hand side shows you what happens when we infuse the gut peptide, peptide YY. That's all we're doing. And what we see is we see changes in the homeostatic and hedonic parts of the brain. The right-hand side of my slide is what happens when there are endogenous changes in the hunger hormone ghrelin. So this means that targeting gut hormones offer an attractive therapeutic target because they're acting on homeostatic and also hedonic brain regulation of body weight. And also they are naturally occurring regulators of body weight. So gut hormones, as you've heard this morning from Dan Drucker, have pleiotropic effects, in particular GLP-1. They don't just act on the appetite circuits. They have beneficial effects on the endothelium, on inflammation, on neuroprotection, which we're going to hear about next. So they have a host of other beneficial effects. So now I'm going to move on to, well, what's happened in terms of targeting these to treat people with obesity. So liraglutide, which is currently available for treatment and licensed for type 2 diabetes and for weight management, is very similar to endogenous GLP-1. So the problem with endogenous GLP-1 is it has a short half-life of only about 2 minutes, whereas liraglutide has a half-life of 13 hours, which means that we can give it once daily, subcutaneously, because it's a peptide. So this slide here summarizes very quickly a high-level overview of the phase 3A trial from the liraglutide studies. And as you'll see from this, the average weight loss is still below the magic 10% that we need to really impact on the more tricky complications that come with obesity. So yes, 8% weight loss is great, but it's, again, not enough. When you're sitting where I'm sitting in managing people with severe obesity, 8% is not going to be enough to really impact and improve their health. So the new kid on the block, which you will have heard about earlier today, is semaglutide, which has got 94% homology to endogenous GLP-1, but it allows for once-weekly injection. So this is a once-weekly injection given subcutaneously. I'm now going to walk you through the STEP program, which is a very comprehensive program in different populations, all using semaglutide as an adjunct to a lifestyle intervention. So step 1, step 2, step 3, and step 4 have all been published, and I'll show you the high-level results from that in the next slide. Then we have regional trials going on with step 6 and step 7. Excitingly, along the bottom, we have step teens, which is about to complete soon, step children, which is from children 5 and upwards. And then there are 2 studies going on in people with obesity-related HFpEF, one in people with type 2 diabetes and one in people without type 2 diabetes. Then step 5, which is recently completed, is the 2-year follow-up study. Then there's a head-to-head with liraglutide and semaglutide, a study looking at the impact on knee osteoarthritis, reversal of prediabetes, and then also a study in people of lower BMI. But the most exciting study on this slide is the SELECT, which is the large cardiovascular outcome trial, which is really going to address the question of whether semaglutide can reduce MACE events. So just to give you a bit more detail on the STEP studies, so these are the baseline characteristics of the people enrolled into step 1 to step 4. So the average BMI here is 38, 37. So again, these are the people who I see in clinic. So people with severe obesity. And again, on there we have age, the majority with female, and HbA1c. So let's start with step 1. So step 1 was the largest of the trial in people with overweight or obesity without type 2 diabetes. And this is the weight loss at 1 year. So on average, 14.9% weight loss. Step 3, which included a really intensive behavioural therapy program, similar weight loss. So this had a 12-week part at the beginning where subjects had a low-energy diet, lots of psychology, lots of exercise, and actually there's not a lot of difference between the two studies. Then step 4 was looking at what happens if you stop the semaglutide, and as you anticipate, people regain weight. And then step 2 is in people with type 2 diabetes. And as you'll see, people with type 2 diabetes have less weight loss with semaglutide, which is interesting, and we'll come back to that later. So in those 3 studies, we're getting double-digit weight loss, but not in people with type 2 diabetes. Now, what if we're looking at categorical weight loss? So up until now, obesity drugs have to achieve 5% to be considered to be licensed by EME or the FDA. So as you can see, 85% achieve 5% weight loss, and even in people with type 2 diabetes, then we're up at 68%. What about 10% weight loss? So this is becoming more important in terms of health benefits. So 70% of patients are achieving 10% weight loss. You also have to look at the placebo group, because this is showing you that the lifestyle intervention with placebo is effective in these trials as well. But still, 70% achieving 10% weight loss. If we go to people with type 2 diabetes, there you go, then 45% are achieving 10%. What about 15% weight loss? So this is where we need to be at to really impact upon NASH and type 2 diabetes remission. So again, half of the participants are achieving 15% weight loss, and a quarter of people with type 2 diabetes. And then finally, if we look at 20% weight loss, so now we're in the realms of sleeve gastrectomy levels of weight loss. Again, a third of the participants are achieving 20% weight loss. So we participated in this study, and I had several patients who lost 40, 50 kilos on semaglutide. And then if we look at people with type 2 diabetes, then it's less. But even still, for me as a physician treating people with severe obesity, it's kind of game-changing. So what about other new treatments? So I'm now going to switch and talk about cagrilintide. Doesn't really trip off the tongue, which is based on human amylin. So amylin is a neuroendocrine peptide that's co-secreted from the beta cells with insulin. And it also acts as a satiety signal. But the big difference is it acts predominantly through the brainstem. GLP-1 acts predominantly through the hypothalamus, whereas amylin is acting predominantly upwards through the brainstem and then feeds forwards. Cagrilintide, which was AM833, is very similar to human amylin, and again, it's been modified, so again, it's a once-weekly injection. So I'm going to show you the data from the phase 2 trial that was published in The Lancet last week. Just to give you an overview of this, so they all had a lifestyle intervention, there's a placebo control, and liraglutide, which is the current comparator that is available, and then a dose response trial to work out which dose is best. Again, if we look at the type of patients who are recruited, again, all of these people are BMI sort of in the higher ranges. And if we look at weight loss, so this was only a 26-week trial because it's a phase 2 trial, then again, you can see that there's a dose effect with increasing doses of cagrilintide, and at the higher dose, it's more efficacious than liraglutide. Now, in the absence of semaglutide, this would be amazing sort of finding, but the problem is because semaglutide was published first, it's kind of slightly reduced the hit of cagrilintide. But as I say, they act on different pathways, which is important. So again, if we look at categorical weight loss, again, you can see that a large percentage of patients are achieving 10% and 15% weight loss. So those are two which are now sort of really, well, semaglutide has already been licensed by the MHRA in the UK for treatment for weight management, but is currently going through NICE. Cagrilintide is obviously going to go into phase 3. But there are lots of other monotherapies based on the gut hormone system. So we have GLP-1 receptor agonists, but there's also oral versions of these being developed. Then GLP-1 and glucagon, which is oxyntomodulin. Amylin-based cagrilintide isn't the only one. Peptide YY is being developed, both as an injection and also as a lingual application, because it's a specific pathway that goes from the tongue to the brain, which is being tried to be mimicked therapeutically. GIP, then GDF-15, and then blocking the formation of the hunger hormone ghrelin, and then FGF21. So for the first time, there is a really strong pipeline of drugs that are going forward for the management of obesity. But obesity, weight regulation is a complicated mechanism because ensuring adequate energy intake is crucial for survival. Therefore, there's a lot of redundancy and we get compensatory changes. So obviously, like any other disease, we're going to need to use combination treatments in some people. So tirzepatide is going to be the closest one to market. So this is a phase 3 study. This is combining GIP and GLP-1. And this is in people with obesity and type 2 diabetes. And the important point here is that weight loss with tirzepatide is better than semaglutide. So for people with type 2 diabetes, then tirzepatide is looking very promising and better than semaglutide. Again, if we look at the categorical weight loss in people with type 2 diabetes, then we've got over 40% of these participants achieving 15% weight loss. So other combinations are also being developed, and this slide just summarizes them. These are the GLP-1 glucagon receptor combinations. So combining glucagon is quite tricky. So glucagon increases energy expenditure, but the flip side of that is you have to be careful in terms of cardiovascular effects. So trying to hit the sweet spot in combining GLP-1 and glucagon is quite tricky. And then what if we combine amylin, so cagrilintide, and semaglutide? So they are acting on completely different systems. And this is a phase 1b study, very short study of top dose, so only 4 weeks at the top dose with 15% total body weight loss. So finally, we're going to be in a situation where we have effective treatments. So the future of anti-obesity medication is, for the first time in my lifetime, looking promising. And underlying that is the acceptance that actually people need medication to help them deal with their obesity. The improved efficacy is absolutely key, because then that will switch the quality analysis that it needs to get through NICE. Combination approaches are key, and we need to sort of continuing to translate the new advances into treatment. So I haven't covered setmelanotide because it's not a gut hormone, but setmelanotide is the MC4 receptor agonist specifically for patients with monogenic causes of obesity. And again, that has been licensed recently for use in the UK. So I'd like to put to you that actually we're finally managing to reframe obesity. We're moving from self-regulation, eat less, move more, through the science which clearly shows that there are complex causes of obesity, and that once somebody's developed obesity, it's incredibly difficult to lose weight and keep it off. And I hope that this reframing of obesity, together with new anti-obesity medications, will absolutely change where we're at in terms of people living with obesity. So I'd like to acknowledge people at UCL, UCLH, the people involved in the trials, and in particular the Obesity Empowerment Network UK. So this is a charity for people living with obesity, and it really informs a lot of what we do, because we need the patient's voice. We need to know what matters to patients, what they want, what are the things that bother them, not just what we're interested in. So they are particularly key to this. Thank you for your attention.